So for those of you who I don't know yet, my background is I did my first sort of medicine training in internal medicine up at UC San Francisco. And what I ended up basically feeling halfway through that residency that I had made a huge mistake, which I actually had. It was not the specialty for me. But when I finished that residency, I decided to go back and do a second residency in emergency medicine. And one of the things that I noticed in that transition from sort of the cerebral specialty to the do something first and figure it out later kind of specialty is that I didn't know how to manage airways very well. It was just something that was, and I also trained back in the day where we didn't have 24-hour attendings. In fact, when I was a resident at Harbor, these many years ago, on Friday at 5, the attending would kind of wave from the door and say, hi, see you again on Monday. And they would leave, and the entire hospital basically was run by residents from Friday at 5 to Monday morning at 8. Which meant that airway management was our responsibility. And as the senior resident, a third-year resident in our emergency department, you were in charge of this completely whacked out, crazy place where the Crips and the Bloods were shooting each other all weekend long, and you had to manage airways, and I couldn't. So I basically immersed myself in airway management skills because we really, honestly, it is us only. So my attending leaving at 5 is like you guys left without anybody to back you up 24/7 in the emergency department. So I immersed myself in airway management, and God bless attendings, because I had an attending back then who was just a wonderful person, and he basically took me in with a mannequin, and we sat and intubated that mannequin until I could do it with my eyes closed. I could do it without even looking, because airway management really is where we make our money. So let's talk a little bit about airway management overall. And we think about airway management, the way it's been taught over the years for our rapid sequence intubation is the 7 Ps of rapid sequence intubation: to prepare, preoxygenate, pre-treat, paralyze and induce, protect the airway, pass the tube, and do post-intubation management. And that's sort of been the structure that we've learned about for airway management for a long time. What I want to talk about in our 2 parts of airway management together is to talk about what of those 7 Ps has changed. Do we even have 7 Ps anymore, which actually may not be the case anymore, and how to make ourselves better. So that's going to be sort of the framework we're going to kind of approach the airway management together with this sort of airway management deal. Well, I'm going to start with abstract number 1 because part of the milieu is what do we do in emergency medicine? How do we do in emergency medicine? And abstract number 1 is part of what was called the National Emergency Airway Registry. It's a big, huge, multi-hospital registry of airway management by emergency physicians. Now, those of us that are a little grayer on the temples remember the era where we weren't allowed to use paralytics, or we had to fight to get paralytic use in the emergency department. And that's what rapid sequence intubation does. Have we earned the right to use that? Are we good at that? And abstract number 1 says, you betcha we are. We are actually phenomenal at this. What this does is basically it's a registry looking at what we do in the ED. This is now, actually the registry now is over 12,000 intubations. I believe it's gotten over 12, but this is 9,000 intubations done by emergency physicians, and basically looked at why we do what we do and how we do it. So medical intubation was 2/3 of them. Okay, so medical intubation, a third was trauma intubations. We used the RSI steps, those 7 Ps, so the RSI, particularly paralytic drugs that go with it, in about 2/3. Almost 3/4 of the intubations. Now, the ones we didn't use it were either people who were out already or codes. Those are the cases where we didn't use it. Surgical airways were less than 1%. And in fact, of the surgical airways that were performed, it was planned as a surgical airway from the get-go in the majority. So that's the trauma to the face. That's the gunshot wound to the neck. That's the person where you say the best thing for me to do from the get-go is to do a surgical airway. So it wasn't that the surgical airways we got there because we made mistakes and oh my God, we have to cut. We actually made the decision consciously. Overall, the success rates were remarkable. The success rates were 97% when RSI was used. So we're just really good at this. We have earned the right. We have basically assumed the skills to do what we do with rapid sequence intubation. We're really good at this. And what we don't have the option of doing, that our anesthesia colleagues do have the option of doing, is if you look at the difficult airway algorithm, and it goes down through blah, 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 you make 3 intubation attempts, what our anesthesia colleagues can do, if you go down their algorithm and it says 3 attempts unsuccessful, it says cancel case. We can't cancel the case. So we are actually really, really good at what we do. The fact that we are stuck in the milieu we're stuck in with God knows what's coming through the door. It could be anything from a 600-pound person who has a big beard and no teeth and just got hit by a car to a little teeny tiny preemie that is given birth to in the car in your parking lot. We are really good at this. So I think we should pat ourselves on the back. We've really earned the respect that we get for airway management. Now, the second thing that's in this is not an abstract that's in the, it's an article that's not in the abstracts, but something you need to know about. Because one of the things that is in all of those algorithms, and one of the things that we've been sort of taught over the eons, is if you're not successful on your first attempt, okay, come on out, bag the patient up, try it again. And that 3 unsuccessful attempts until it's considered a failed airway is sort of this milieu we've practiced in that gives you this feeling of comfort of, well, I'll give it a go. But if I don't get the intubation, it's all good. I'll just come out, bag the patient up, and try again. John Sackles published an article in January of 2013 that actually kind of turned that whole thing on its head. And for those of us who teach airway management skills to trainees, it actually has led to a little bit of an ethical dilemma. What he did is in 1,828 intubations, what they did is reviewed the data, looked at number of adverse events that occur based on number of attempts to intubate someone. And it's actually a very simple premise, remarkably simple premise. I'm surprised someone didn't do it sooner. And one of the things when you look at papers like this you want to do is you want to say, look at it and see, what if they call an adverse event an adverse event, do you agree? Do you agree with what they listed as adverse events? So let me tell you what they listed, first of all, that when they went through all these charts, what they were looking for. It was accidental extubation, aspiration, cardiac arrest, cuff leak, dental trauma, dysrhythmia, esophageal intubation, hypotension, laryngospasm, main stem intubation, which is one you could question maybe, oxygen desaturation, and pneumothorax. Okay, all of those are pretty hefty as far as complications. I'm good with all of that. That's good. They didn't say, intubator got nervous, family member had a conniption fit. None of that is in. This is all real deal stuff. This is all the real deal. And so what they did is it looked at how many of those things happened depending on the number of intubations. If you're on your first intubation attempt, there were 14% adverse events, a majority of which, by the way, were desaturation. If you went to a second attempt, those adverse events tripled. Tripled between attempts 1 and 2. They went to almost 50%, 47.2%. If you had to go to a second attempt, you now had half of your patients have some sort of adverse event. That is a huge deal. For those of us who teach trainees, this really has led to a bit of a dilemma. Is it right? Is it ethically defensible to let a trainee futz around and figure it out? Is that defensible? Should we be training people on simulators until they're really, really good before we ever let them at a bedside? And actually, this article I brought up to a resident of mine just on my last shift with him about a week ago. He's graduating, and one of the things he did, we had a woman need to be intubated. We did all the right things as far as assessing her. It was all great. He wanted to try it with a straight blade. He wasn't very good with those yet. I said, okay, that's fine. We got all our backup equipment. It's all good. But he didn't put her in the right position, and I talked about it. I said, why don't you stick her in the right, let's kind of get her head extended and neck flexed, and let's get her in the right position. He said, no, this is good. Well, it wasn't good. He didn't get her intubated on the first attempt. We had to go to a CMAC for his second attempt, which was successful, and thank God nothing bad happened. But I asked him later, I said, what was the deal with not wanting to put her in the right position? And he said, I really want to challenge myself here at the end of my residency. So I on purpose made it a little difficult so I could kind of troubleshoot it. That is an ethically, I think, indefensible position. And we talked a lot about it. I said, I understand your need to learn. But the problem with that is this article and experience that I think a lot of us have is that if you don't get it the first time around, your patient has a significant risk of suffering, of having a bad event because of that. This paper, I think, really proves it, and I think a lot of us have experience in that. What were these adverse events in this particular paper? Well, the oxygen desaturation was 40%, and that was actually even on the first go-round in a lot of them, but aspiration was 6%. Aspiration can be absolutely lethal to somebody you're intubating. Think about the reasons we intubate people. If they aspirate and they already have pneumonia or they already have ARDS from sepsis, that's a bad deal. That's a terrible deal. And esophageal intubation was about 16%. And again, a lot of those were the first to second attempt failures. I think the take-home point on this, honestly, is if we know it's going to triple between 1 and 2 attempts, we are going to make that first attempt the best it can possibly be all the time. Every single time, so that we can be of the highest likelihood of success on the first go-round. So if that's the case, Let's figure out what we can do, and that's what we're going to do together in our remaining time together, is figure out how we make the patient, the whole situation, the best possible to be successful that first go-round. So that first P of rapid sequence intubation is to prepare. And what you're preparing in that first P is your personnel. Make sure the nurses know who's pushing the drug, the RT knows when and what to do, so you tell the RT what to do. You prepare your equipment, and you need to have at least one backup. I recommend strongly having a bougie for all cases, one extraglottic device, I don't care which one you pick, an LMA, an iGel, whatever, a King LT, something, one extraglottic device, and one intubating device. If you have a videoscope, that's great. In addition to your DL, if the DL is what you go to as your go-to first thing. So you have several options if things don't go well. You can grab that bougie, you can slide in an LMA if you need to oxygenate them, whatever. But prepare all of your equipment. Prepare the patient, so make sure the access is good, make sure they're in the right position, make sure that they have all this, they're on the monitor, all that jazz, and then prepare yourself. One of the best things you can do to arm yourself for not having that got to go from 1 to 2 attempts intubation is to troubleshoot in your head ahead of time. What if? So for instance, my favorite what if of my entire career was a resident looking down there in the airway. Everything was cool. It looked like it was going to be totally simple intubation, no big deal. A person from a nursing home, it was super easy. Looked in there and said, oh my God, he has a tumor. I was like, what? So I can't even see the glottic opening. There's this just big fungating tumor down this guy's airway. I was like, oh my God, really? So I took a look. If we had a video scope, we could have all looked together, but took a look in there, and it was this lumpy, bumpy, really rough, verrucous-looking green tumor that was broccoli, stem down, right through the cords. So this is a partner. The guy coded in the nursing home because they gave him broccoli. He inhaled it. Its stem went right through his cords. That lovely little floret was what we were looking at when we were looking through the DL. And what we needed right then and there was McGill's, which of course we didn't have right then and there. So troubleshoot it all. That's why your equipment needs to be there, because we had to scramble around to find McGill's to get the thing out of there. Thank God for suction. Just crammed the suction on there and got it out. But that's what the preparing is. The what ifs are really helpful. So now every what if we go through is what if we find broccoli. So that's like the harbor what if. What if we find broccoli? Because you never know what you're going to find. So that's the first P, is to prepare. The second P is to pre-oxygenate. Now, one of the sort of dictums of rapid sequence intubation is the minute it crosses your mind that you're going to need to intubate somebody, you're going to look at their face first thing and see what's on there. If there's nothing or a nasal cannula, actually leave the nasal cannula on. I'll come back to why. But add a non-rebreather mask. Now, we've always thought that non-rebreather is plenty good, but it turns out it may not be. And what you need to do about pre-oxygenation now is have a thought process on how you're going to maximally pre-oxygenate somebody. And one of the concepts is to remember, you're not just pre-oxygenating, because right now you guys you're at sea level. It's like right there, sea level. You now have the most oxygen in yours should be a saturation of 99 to 100%, all of you in this room. However, in your lungs right now, that lovely multi-liter reservoir in your chest, you have 21% oxygen-ish, maybe 20% plus 1% smog. And then you have 80%-ish nitrogen. It's lurking in there doing nothing, but taking up space. But your oxygen saturation is 100%. Looks on a pulse ox, it looks like you're doing fabulously. But I've lost my ability to have a reservoir. If I need to intubate you, what I'd like is that whole lung volume to be a reservoir of oxygen. So what I need to do is wash out that nitrogen, denitrogenate, and instead fill it with oxygen. Now, for all of you guys, if I stuck you on a non-rebreather here, and you breathed normally for 3 to 5 minutes, you would wash it all out, and you would have this whole reservoir of oxygen, which is going to give you a ton of extra time. So if I take this healthy young man in the front here, and I decide to pre-oxygenate him with a non-rebreather for 3 to 5 minutes, and then I take my trusty succinylcholine blow dart, and I drop him. So I just take him down with sucks, and he lies on the floor paralyzed for 10 minutes. Will he desaturate? He won't desaturate. He'll wake up, he'll never desaturate for the entire duration of the succinylcholine because he's young, he's healthy, that reservoir is now all oxygen, and I bought myself 5 to 10 minutes of great oxygenation in him. It gives me that opportunity. So again, we're maximizing our ability to intubate somebody on the first attempt, and one way to do that is get lots and lots of oxygen reservoir. There's a whole set of articles that have come out recently in the last couple of years looking at this concept of preoxygenation and denitrogenation to get somebody basically perfused with oxygenated blood the best possible. One of the papers, by the way, if you haven't looked at them yet, your 2014 LLSA papers for the US board certified folks here. It's one of the articles you're going to have to read. It's written by Weingart et al. It's wonderful. That looks at the approach to maximizing somebody's oxygenation and denitrogenating them, getting all that nitrogen out. So a couple ways you do this. There's actually a sequence of steps to do, and a couple of nuances of this that you want to integrate into your practice, again, to become a best practice. One is make sure the non-rebreather's on from the get-go. And know that a non-rebreather gives you about 70% oxygen. We used to write down 100% non-rebreather. It's not. It's about 70% oxygen. If you can't get them saturated up to as high as you'd like, get them that they will get with that, you can then put a bag valve mask on their face. A bag valve mask actually it has the bag reservoir and the tube. So basically what you have here is everything in that system is oxygen. Okay, versus the non-rebreather, which is this little thing here in that stupid little bag that is not really doing a whole lot. So now I take this big bag with the tube and I put the mask on their face so I have a closed system. Okay, the problem with that system, just so you know, is most of those bags have a duckbill. So if you look in the mask itself and you look where the bag attaches, there's this little thing that does like this. Okay, that's a duckbill. If the patient isn't able to inspire, if it's not sealed well and they don't inspire strongly, that duckbill will stay closed. So what they're getting is they're recirculating just what's in the mask here. So what you want to do to get the highest amount of oxygen delivered in a spontaneously breathing person is go ahead and put that mask on, but squeeze the bag just a smidge so that duckbill opens. That the spontaneously breathing person is breathing the most amount of oxygen you can supply in their spontaneously breathing circulation. So that's your next step. Non-rebreather, okay, well, I need to give more oxygen. Now I'm going to do this mask with just keeping the flow there. If they're not breathing well on their own, then go ahead and assist them. If they're having some ventilation, coordinate with them. If they're not, give them 8 vital capacity breaths. Stick that mask on, do a good mask seal, 8. And that's the whole thing, not just your normal tidal volume. That's like squeeze the bag till they inhale completely 8 times. That'll wash them out the best you can. And again, what you're trying to do is wash out the nitrogen and put in oxygen. So that's sort of your sequential increasing in oxygen delivery. You can, if somebody, so say you do all that stuff, you have them, you're trying to assist their ventilations, and they're still sitting at 88%. The problem with 88% is you're on your oxygen desaturation curve and you're plummeting. That means their PaO2 is 50. Okay, it's really low, and they're going to crash and burn the minute they stop breathing. You can consider non-invasive ventilation. You can strap on the mask, you can go ahead and put them on particularly full face mask, non-invasive ventilation. Just be aware of that though, because part of the problems is that they have a risk of aspiration with that. So be careful with it, but it's something, as long as you're at the bedside, consider going ahead and you just hold it on their face and turn on the non-invasive machine to get a little more oxygen delivery. And if they're fighting you with that, one of the sort of nuances is to give them a little dose of ketamine. They're awake, they're breathing, they're protecting their airway, but they're not fighting you quite so much, and you might be able to get them oxygenated a little bit better. Such are sort of your sequence in getting them oxygenated. Position the patient with the head up if possible, because you perfuse your lungs. Your VQ, as far as your ventilation and perfusion match, is the best when you're upright. Okay, that's the way your lungs like to be. Lying flat, not so good. So if you're having somebody you're having trouble oxygenating, put their head of the bed up a little bit or stick them in reverse Trendelenburg. That should help as well. That'll help you get them oxygenated. And then one other thing to remember is what's called apneic oxygenation. The reason that you're going to leave that nasal cannula on, or put one on purpose, is that if I were to take any of you, and so I'm going to take this gentleman, and I'm going to not preoxygenate him, but I'm going to take him down with sucks. He stops breathing. But if I take a nasal cannula and I now I crank it to 15 liters, I'm shoving a lot of oxygen down into his lungs that perfuses just passively without him having to breathe. What that apneic oxygenation does, our anesthesia colleagues do it all the time. They do it all the time in the operating room. What that does for us in the ER is it gives you a little more time. They actually will passively oxygenate. So your sequence is going to be keep that nasal cannula on, but turn it down a little so it's not uncomfortable. Put the non-rebreather on, turn it up as max as it'll go. Once you get the patient paralyzed, the non-rebreather comes off, you turn that nasal cannula all the way up so you get passive oxygenation with it, apneic oxygenation, and that will give you more time. It's a best practice, so it's something to add to your practice, this passive nasal cannula oxygenation called apneic oxygenation. And then the last thing to remember as far as oxygenation and sort of ventilation is concerned, as we go through this preoxygenate step, is that and we almost had a clean kill on this recently in our emergency department. Say you have somebody who comes in with a toxic alcohol ingestion, and their pH is 6.9, okay, because they've ingested toxic alcohol, and they have that horrible organic acidosis, that metabolic horrible acidosis. The problem with that is, and they'll sit there with a respiratory rate of 36 or 40, trying to blow it off, right? They're trying to get a respiratory compensation. Now I take that person, and I stop them breathing. I paralyze them. They're going to get a respiratory acidosis on top of their metabolic acidosis, crash, burn, and die. So one of the things to remember is in the profoundly metabolically acidotic person, who in order to compensate is breathing is tachypnic. That's the aspirin overdose, the toxic alcohol, the AKA, the DKA are the big ones that do this. You are going to need to continue their ventilation, try to mimic what they were doing physiologically once you've paralyzed them. Respiratory acidosis happens fast, and you're adding it on top of a profound metabolic acidosis. So one thing to remember is those people will, because in rapid sequence intubation, we teach never bag. Oh, don't bag them. You don't want to insufflate the stomach. Well, this is a case where you are going to bag. The minute they stop breathing, you take over for them. You bag them until you can get them intubated. Another thing to consider is to give an amp or two of bicarb. So dust it off. It's somewhere dusty in your storage unit somewhere. Get the bicarb out and push an amp or two of bicarb ahead of time. But the thing in all of this sort of oxygenation, denitrogenation concept is to get the oxygen the best you can, wash out all that nitrogen, and remember, if somebody really needs to be breathing from a metabolic reason, that acidosis is terrible, mimic their breathing until you can get them intubated. So that's sort of the preoxygenation step. So we prepared, preoxygenated. The next step in that rapid sequence intubation list is pre-treat. How many of you routinely give pre-treatment drugs to your patients you intubate? Excellent. That's actually the perfect answer. So this has been taught forever. If you go back through your textbooks, so you go through your emergency medicine textbooks, there are mnemonics, things like load, lidocaine, opioids, atropine, defasciculation. All of these drugs were thrown in there with the concept of, if I decide to intubate someone, if I stick something down in their trachea, I have both the laryngoscopy and sticking down the tube itself are a profound stimulator of your autonomic nervous system. Profound. Think about it. You aspirate a little teeny tiny drip of something, you end up coughing your brains out, right? So now I'm going to put drugs down somebody, or put a tube down somebody and stimulate them. Turns out that load, lidocaine, opioids, atropine, and defasciculation, turn out to be not useful in most cases at all. And if you've dropped using pre-treatment drugs, you are actually right in sequence with most people out there. And it turns out that there's not a lot of proof that any of this works for us at all. So the load mnemonic itself, all the pre-treatment drugs turn out to not be particularly helpful at all. So if you've dropped them, it's fine to do. So this first half hour we have together talked about preparing, pre-oxygenating, and pre-treating. What we're going to do in the last half hour together is talk about the rest of those P's of rapid sequence intubation. So any questions on this stuff?